This is the Health and Politics podcast. Prevention is the new cure.
And that's with former ministers Steve Brine and myself, James Bethell.
Good morning, James. Not much going on.
I know. It's unbelievable, Steve. It's meant to be like a nice, calm administration to restore credibility to the country. It's blown itself up.
As they used to say, hashtag end the chaos.
I know. It's incredible. And Trump's in China, and Straits of Hormuz are still shut, and I don't know. It's just like, it does feel angsty, doesn't it?
It does. I mean, look, we should explain, as we record this at just after 9 o'clock on Thursday morning, which is the usual slot we record this, Wes Streeting is, he says confidently, the Health Secretary. But yesterday, members of the Cabinet out on the media round were unable to say whether Wes Streeting was the Health Secretary. And that's because all eyes are on him and Angela Rayner and to some extent Ed Miliband as to whether they are going to fire the starting gun of a Labour leadership election. Zubir Ahmed, who you and I have talked about before, who was a health minister until a couple of days ago, resigned earlier in the week saying that he felt the Prime Minister had to go and he did the honourable thing and therefore resigned. I think that is a shame. Sorry, we know that he's not a health minister anymore, and I'm sorry to see that because he was perceived to be a good thing and very much credible within the data space, which he was his brief, wasn't he?
Yes, but it's a political calculation, not a personality thing. I think it's the smart thing. If you're a junior minister, but with an eye on the big prize, like he does, then it's a not bad gamble to go early and gain the credit. And when the history of this is written, his name will be up in the first chapter, which is not a bad place to be.
Yeah, I see that the HSJ are reporting this morning that the Department of Health has churned through 47 ministers in the last 11 years.
I used to run an Excel spreadsheet of the Guild of Former Health Ministers.
Yeah.
It wasn't, there weren't that many of us. It's now suddenly exploded.
Do you know what though, James? It's about quality over quantity.
I hope so, yeah.
Isn't it? The reason why I think, that matters, doesn't it, is because... And this sort of goes to the wider point here about the chaos that's engulfing the government and the crisis that's engulfing Keir Starmer is that, civil service does tend to go on a go slow when these things happen because they're just not sure where the pieces are going to land. They're not sure who their bosses are going to be. And it was interesting that Jess Phillips, who you and I both know, resigned as a Home Office minister earlier in the week as well. And she said, the Prime Minister had to go, but she also made it about some work that they've been doing. And I saw that you tweeted about it and how frustrated she was with number 10 being so timid, not being able to get an answer out of number 10. And then I saw that survey that ASH, the anti-smoking group, put out this week, which said that, the public are now overwhelmingly in support of banning smoking in pub gardens. And if you remember, very, very early on in this government, in this Labour government, they were going to do that, right? And then there was a little bit of noise from the back benches. And what did they do? They backed off. And that really was a sign. And we saw it then with welfare reform writ large, didn't we? Is that the government, the Starmer government, is very timid. It is very incremental. It doesn't like to make big, bold moves. And I think in a way, Jess Phillips, not for the first time, somehow encapsulated that in the letter that she wrote. Did you see that?
I did. It was such a potent letter. But Steve, you're understating it hugely. This is the whole story of the last 18 months. I mean, we were all in deep conversation with the health team before the election about their ambitions for change when they came into power. And I think that the granting of the big pay rise to the doctors, that was a strategic mistake, and that's very much on Wes personally. But I know that they went into office with a whole ton of ideas for how they could move things. Ideas which, by the way, were pretty much the same as the 3 shifts that we were talking about in office. Nothing happened. And why was that? It was I think when the history is written and people have published their confidential thoughts on this, it'll emerge that Downing Street shot down absolutely everything whatsoever, anything to do with prevention, to do with moving stuff around. And the big move of the last 18 months has been the abolition of NHS England, which we all know happened in desperate circumstances because of the trouble that they had around appointments, and happened as a sort of snap decision, not as a strategic move that had ministerial sign-off from around the cabinet. So, this paralysis that Jess alludes to in very sort of vitriolic and persuasive terms has hit the whole of government and in our space, health, really hard, I think.
Yeah, just the other thing I want to say on this is that, and I did say this during the last government, FYI, in case anybody says, oh, now he says it. Look, whether it happens today or tomorrow or next week, there is going to be a contest for the Labour leader and therefore the Prime Minister. I think that the state should legislate to say that if you are in office, you cannot change your leader without it being just a decision for the MPs. I do not believe that it should go to the members when you're in office because, we did it and the MPs chose, we chose Rishi Sunak. And of course it went to the members chose Liz Truss. And, I give you history. What could well happen here with the Labour Party is that the members choose somebody who they work with day in, day out, who they think could handle the job of being Prime Minister. It goes out to the members and you get, the Jeremy Corbyn figure who could of course be Angela Rayner in this context. I just think it's totally wrong, James. And I think it's almost verging on a little bit corrupt that you could pay 25 quid to be a member of a political party and you get to choose the Prime Minister of this country. In opposition, totally different kettle of fish. Totally different because you are choosing somebody who represents the party at national level. In government, you're representing somebody who represents the country at national level. And I think it's totally wrong. Of course, that won't happen unless they have a coronation and whoever takes over from Keir is just sent into the job like Gordon Brown was. But I think it's totally wrong that the members go, discuss.
Yeah, I listen, you've got a point. And I know that in America, in some elections, the parties decide who the candidates are. And that has always struck me as being rather weird and sort of, as you say, sort of smacking of corruption. But I think that state mandation for how parties choose their leaders troubles me because it feels clunking and interfering. But listen, you've got a point, and ultimately the members of the party should factor into their decision whether or not that leader is going to be able to prevail with a majority of their own MPs. But you're right, in the Liz Truss case, that didn't prove to be the case.
No, we chose Rishi, and that's clear. Yeah. Of course, the sad thing about all of this is that there are GDP figures out today which are not terrible. Actually, they do show some small morsel of growth. And of course, all the media are talking about, because that media merely follow what the politicians are talking about, is leadership speculation. Anyway, what have you been up to, James? Getting beach ready, I hear.
Yeah, well,
what does that look like in Bethell land?
Oh, God, and nothing particularly fantastic. But I just was reflecting that summer is coming, and I've got a big summer holiday in July, and I do feel pressure to look good on the beach. I mean, I really do, and I am now, laying off the booze and avoiding the biscuits and trying not to eat the bread and, just doing the basic stuff to get my weight down from the number it is at the moment to the number I know it needs to be. And it's good for my health anyway. But it's hard. And then trying to do just a bit more exercise and chisel out some time. I mean, these are good disciplines. I strongly support them. But I just thought I'd emote that, it is a struggle and it's a pain. And, I carry a huge amount of pressure and angst and cortisol and sleeplessness and trying to mix into all of that nutritional restraint and physical exercise. I'm just sort of sharing with you what a struggle it is.
I mean, absolutely. I mean, your Daniel Craig moment as you walk out of the...
It really won't be that.
Well, I look forward to the picture on your social media.
Slightly less of a muffin donut kind of look.
Okay, on that visual image. Listen, it's so great to have people listening, isn't it? Welcome along. We're two former health ministers, so two of 47, as they like to say. We discuss the big stories in health and politics. We do that every Thursday morning, and we're really grateful for you listening to us show, actually. And if you hit subscribe, you get our brand new episodes as you do. You can WhatsApp us on 0333 404 6507, or you can email us hello@preventionisthenewcure.com. A number of people have, and we're going to bookend the show. Well, we're going to end the show today with two very interesting voice notes that listeners have sent us. But in terms of what we got coming up this week, James, we're going to start by talking about the King's Speech, which was yesterday, Wednesday, and it contained that rarest of beasts, a new health bill. So we're going to talk a bit about that.
Yeah, a new health bill. It's going to be a very important one. Then we're going to discuss Hantavirus. How did we get here? And how worried should we really be?
Yeah, interested to hear that. And finally, as I said, we've got two listener-led items, as it should be, of course, starting with alcohol. So events in Westminster, not to mention world events, may be driving some to drink, but we're going to are we making progress or are we going backwards on preventing deaths from alcohol. We're going to talk a bit about that. And then secondly, all around the shift from acute to prevention, we've got a really great question from a resident doctor. So, back to the top, James. King's speech yesterday. Charles III, of course. King Charles III was in Parliament. And just briefly on the personal, presumably, you had you were watching with interest as they were there in the Lords. It's the first King's speech with Loyal address that you haven't been there in the Lords. And it's an amazing spectacle, isn't it? What are your memories of King's speech day from your end? And then I'll give you from my end of the green benches.
Oh, it's a hell of a thing. I mean, no, honestly, it really makes me proud. No country does it as well as we do. I was a Lord in Waiting a few years ago and went to Buckingham Palace and rode in the carriage from Buckingham Palace and then walked down the procession and stood next to the Queen and then went back for tea with the Queen. Steve, it was the happiest moment of my life. I won't hide it from you. It was fantastic. And it is the pomp and the history and the personalities and the care and the consideration that goes into it all and the thoughtfulness of it. It is a beautiful thing, and it's a celebration of this weird constitution we have, that we stick the most powerful person in the land into a tenement house in a sort of dowdy SW1 cul-de-sac at Downing Street, and we give to the king the gold carriage and the page boys and all of the pomp and ceremony. And I like that. I like the fact that we don't have a president. I'm glad we don't have Trump and Macron and a big plane and swanking around and that huge desk with the vulgar gold curtains. I like the way that we do it, and it really makes me proud.
Oh, I love that. For those who wonder what James looks like sitting in a carriage, you don't have to wonder, because I happened to saw that you posted that picture, James, didn't you, on your LinkedIn, which we will share on the show channels after we've recorded this. You were in your top hat. And I suppose memories from the green bench end is that, and I was glad to see yesterday in the King's speech debate, that even the Prime Minister, there was lots of jokes and it was very jolly, because King's speech, Queen's speech day is a very big moment for Parliament, as you say, but it's also a kind of happy moment because there's lots of stress. And of course, there is at the moment alongside the happy moment. But I always remember Desmond Swain, the MP for New Forest West, used to wear his morning suit and sometimes even a top hat on the day of the Loyal Address, because MPs traditionally would get dressed up and wear a morning suit for Loyal Address Day.
That's what my father did.
People in the tea room, there's a little buzz of excitement in the tea room as people are talking about, when does the sovereign arrive? Are you going to go out on the gates and watch the procession come past? And there's drinks receptions afterwards, isn't there? And it is a lovely day. It's very much the first day of term feels. There's lots of hope and expectation around the King's speech. And I always used to, I started off sitting in the chamber because you want to be inside there when Black Rod bangs the door 3 times. But I must admit that in latter years, I would sort of linger around in members' lobby, because what happens is, as you'll see on the television, people who are listening, is that obviously the Speaker and the Commons MPs, led by the Prime Minister, lead the opposition, they process down to the Lord's End. And if you want to get in to watch the Loyal Address, then not many MPs can go in and stand at what they call at the bar of there. You've got to basically be pretty much behind the members of the Cabinet to be able to do that. So if you hang out, is a tip for new MPs, if you hang out in members' lobby, you can then just duck in behind the front runners, and then you can stand in the chamber and get a peek of His or Her Majesty as it was in our time, and watch the King's speech. But that's all the pomp, that's all the ceremony. Of course, most important is what is said, and it contained 2 health bills, I suppose. So you wait for a while, you get 2 along at once. The Draft Conversion Practices Bill, that's going to deliver this promised ban on measures intending to change someone's sexual orientation or gender identity, which is going to get a lot of noise. There'll be a lot of attention on it. But we're going to focus on this, what's called the NHS Modernisation Bill. That is going to abolish NHS England, which of course the Prime Minister announced now, goodness, at least 14 months ago was going to happen. It paves the way for a single patient record, which we are going to focus on, and for patient records to be viewed on the NHS. And it's going to require mayoral nominees to sit on local health boards. So it's a big deal that there's a health bill. And I think the worry for ministers will be that it's going to be what they call a Christmas tree bill, where you can tie anything on to any branch, and anyone with a piece of interest in health or an axe to grind can put forward an amendment. That will happen. It happened in the 2012 bill. It's going to happen again on this one. But initial reflections from us, James, on a new health bill.
Well, listen, this is good process management, tidying up a ton of loose ends. We don't need and don't want another, omnibus bill and a lot of programmatic reform. And tidying up the NHS England abolition is a good thing to be doing. That said, I would have loved to have seen something that kind of tackled some of the big shifts that are going on. It would have been good to slightly rewrite the social contract between the consumer and the health system to give patients both more rights and more responsibilities. That's a sort of meta point, but maybe this isn't the moment for doing that. What is exciting, though, is trying to tidy up the data side of things and moving the responsibility for the data from the GP, where things really did get stuck, up to the department. Might sound like it's a centralizing move, but actually it's going to free up a whole bunch of data. So I'm really pleased to do that, to see that happen. And then in terms of the NHS England reform, Steve, I remember standing up at the dispatch box during COVID 1,600 times to defend NHS England, basically, and to talk about the health of the country. But I didn't have any reach into NHS England. And if I tried to phone up the chief executive of NHS England and ask him a question, his assistant would tell me that he was too busy to talk to junior ministers. Massive firewall and a cultural and institutional and legal firebreak that was really out of, it wasn't working anymore. I was also aware of a huge amount of duplication. I mean, on the whole, blaming duplication for things is not true in Whitehall. Resources are typically quite stretched, but on this occasion, it was very difficult to thread the needle between both DHSC colleagues and NHS England colleagues, and therefore a lot of things just got stuck in treacle. And then lastly, on the mayoral nominees, I'm really optimistic about that. I think that that's a really important constitutional change that we should be excited about, because ultimately health is done better locally, not everything, but we don't have the local structures for either governance or accountability. And I think that these nominees could really make a big difference. What do you think, Steve?
Well, let's go into the single patient record, which, just for those who don't know, I mean, the idea of what it's going to do is the bill will create a legal framework, I suppose, for a new national single patient record, which will be viewed by the acute sector, by primary care, by the care sector. It's going to be a challenge because, of course, they are not part of the NHS, as is not a lot of primary care. And it's going to compel, that's the key word, I suspect that's a legal word that will appear in the bill, it's going to compel the data sharing between NHS organisations and then feed that to support patient access through the NHS app. And it feels to me that that's the right thing to do, but it feels that government have concluded, and I think this is probably quite an important shift in NHS philosophy, that interoperability, which is what you need, is now too important to be left to local consent and voluntary cooperation. And, it's like we've had enough. We're now actually going to enforce this and make it happen. And I think if you are going to do what we care about, which is to manage population health in an intelligent, forward-thinking, modern context, I think you absolutely have to do that, don't you? So I suppose where I'm concerned for it is the Christmas tree bill analogy that I said, but more that, and this is where politics becomes the health impact. Will all of this, and inevitably when you say the word data in the context of health, people say Palantir, it's like a kind of tick on that word. Will all this now get tied up in the race to play to the Labour Party gallery, as we were talking about at the top of the show, with Palantir, and will we activate the break clause? And I know we've talked about Palantir before on the show. That's where my concern is, because when we've talked about big data programs in the past, when I was a minister, effectively what happened is number 10 panicked and number 10 backed off. And my concern is that you will see the politics of the Labour Party override what we consider to be the reality of what's needed in data health management. So I'm trying to be positive, but that's my anxiety dream.
Steve, I mean, you're right to be worried. It does create some toxic electricity around it all.
Yeah.
The The reality is, if you speak to the voters, and we did a huge amount of research when we wrote the Data Saves Lives white paper, which is a very important intervention. And I went to some of the focus groups and had a readout. It's amazing what people actually say. Of course, they're worried that confidential data about what happens in their underpants gets shared quite reasonably, and a few people do cite that, but not much. What people really say is, I am an individual. I am fed up with turning up and being treated like a commodity. I'm fed up with turning up and they don't actually know anything about me whatsoever. And
Absolutely.
I have to go over everything all over again. And I need to be treated in distinctive personal ways because my conditions and my reaction to medicines and treatment and engagement are very, very personal to me. And I want you to know everything possible about me. I am fed up with starting with a blank sheet and you brushing off everything that I say. And that's actually that is the very strong invective you get from patients when it comes to data. So this idea that the number one concern of people is cybercrime and sharing their data is just not correct when you
I agree.
actually talk to people face to face about it.
I absolutely agree. I know people have frustrations when they talk to their bank, but generally speaking, you call your bank through your NHS, through your banking app. They say, "Oh, hello, Mr. Brine," and then we have a relatively informed conversation. They take me through security, but we have a relatively informed conversation. That's just with my bank. But when I have a conversation with my clinicians, as you say, it's always back to square one. So I suppose the bill.
No, I mean, Thames Water do a better job than
Yeah, absolutely, and that's saying something. So I suppose the bill. It looks to me, and of course we haven't seen the draft bill, it hasn't had what they call first reading yet, but it's a centralisation bill, it's a digitalisation bill, it's an accountability bill, more than it is a traditional health bill. I did an event, I was saying last week, with Layla Moran, who chairs the Health Select Committee, took over from me, and I was asking whether they're going to do any pre-ledge scrutiny on it. And rather worryingly, they offered and were politely or impolitely declined, which I think is a mistake, because actually, it's a really good chance to make sure that you've got it right and you've got the experts on the Health Committee looking at it. But
I agree.
So I thought that was a mistake. But I suppose the sort of final observation from me on this is that it's the biggest NHS governance reset since the 2012 Lansley reforms when I was in the Commons, but it's being done in reverse. So Lansley decentralised and fragmented, and there was much decrying of that. This package sort of re-centralises and integrates. And it could just be that meets the moment because of the conversation that we've had about data. But of course, as ever, the proof will be in the pudding, and a draft bill is very different to a bill that crosses the line and gets royal assent, as we found in 2012. There's a long way to go on this.
I think that's a crude characterization. Mandating the sharing of data is not a centralizing measure. It actually is quite the opposite. It means that if you're moving around the country, your records move with you. That if you have one thing in one doctor, it's shared with a hospital. The movement of data actually empowers more flexibility. And when I work on programs on things like obesity or on smoking, which we're going to talk about, the ability to see into the system what the costs and movements are from the top actually allows you to commit to big programs and treatments. It really, I think it's not helpful to just say that it's either, the fat controllers in charge or it's all sort of mayhem on the front line. This is about, honestly, it's really about modernizing it and just bringing health up to the same standards as basic utilities like water and gas and electricity.
Yeah, I think what we agreed, didn't we, that that data management piece is really important. But we also agreed that government have sort of come to the end of the line on the interoperability just being left to systems.
Yeah.
And that's what I mean by the centralisation part of it, is that they are being more muscular. And I welcome that. I think I am an interventionist, and the more I go on, it probably more so than I was when I was in government. I think I am an interventionist because I think I've come to the conclusion that you need to be so in data terms if we're going to achieve what we know we need to achieve in the budget envelope that we've got on prevention. Anyway, fascinating.
I think the thing that what you haven't said, which I know is what the centre is doing is challenging those people who don't want to share data because of their various anxieties about whether they may be subject to historic claims or performance targets, or actually be challenged by their own patients about the kind of service they're getting. That's really what the challenge is, and I welcome that challenge.
Yeah. Let's move on. Let's go offshore. Hantavirus, how worried should we be, which you mentioned. I'm just going to read you this, James. There's no sign of a larger hantavirus outbreak after the evacuation of the last passengers this week from a disease-stricken cruise ship, the head of the UN Health Agency has said. But World Health Organization chief Tedros, who you and I both know, warned the situation could change and there could still be more confirmed virus cases. So that's clear then. The facts of this story are that 3 people sadly died on the Dutch ship MV Hondius, which has now offloaded its passengers, including Brits, to Arrow Park Hospital in the Wirral, which was used for the initial COVID patients, of course. Hantavirus is a group of viruses carried by rodents. It's found in some areas of Europe, Africa and Asia. So while most hantaviruses don't pass from person to person, rare instances of human transmission have been documented with the Andes virus strain. I think there's lots of questions around hantavirus. It's a story that probably would have had an awful lot more purchase but for world events and domestic political crises. But nonetheless, I think it's worthy of us talking about it because you and I have quite a lot of experience of dealing with disease outbreaks. How much, you were in the States last week, how much did you see this story reported in the US media, James? Was it there?
No, it wasn't. And, the American, the American culture at the moment is, they hated COVID so much, and the administration is so skeptical. This kind of thing doesn't get any coverage at all. And listen, from what you can glean from the reporting, that the anxiety levels that this is going to become a highly transmissible global pandemic is not high. But these things can mutate, and I mean, we can talk about it in a moment. But it triggers lots of anxieties for me. What did you think, Steve?
Well, they all say this is not another COVID, but they then go on to qualify it and say what you just said. But so it doesn't, as I understand it, it doesn't spread easily through the air in day-to-day life. So it's not a respiratory illness, therefore it's not behaving like COVID or flu or measles. And all the agencies, the WHO, UK Health Security Agency, CDC in the States, they're all saying the risk to the wider public remains low because transition requires you to have very close contact, prolonged exposure, and usually contact during the symptomatic illness as opposed to during the incubation phase. So it's much more akin to a contained infectious disease incident than it is the start of a pandemic. I suppose that is true, and therefore it lends itself to the very close quarters of confined living, shared ventilation, prolonged exposure, delayed evacuation, and can't get away from people, which is what happens on a cruise ship. I suppose ultimately we should be using the experience of COVID. And we should be using the incubation period experience to make sure that it doesn't break out. And I think it's, I may be proved wrong by this, but my hunch is that it's very serious for the individuals affected. And of course, condolences to the 3 people who've passed away, but it's not currently a serious threat to society. And I think that's probably where I would land on it at the moment. What do you think's going on in Arrow Park at the moment? They're very experienced people up there. And as a minister, presumably during that time, presumably you had some contact with those people up there.
Yeah.
They're very a lot of contact, but they're very good, aren't they? And they're very experienced. And they were, to be fair, they were before COVID very experienced in containing sorts of outbreaks. They had a lot to do with them.
A huge amount. And when the Princess Royal docked, they handled that incredibly tricky situation very well. I think there are 3 things that really strike me about this. One is it just reminds me to think to myself, I wonder what's happened to all of that pandemic preparedness that we built up and that we should have mothballed and had ready for another day. The Joint Biosecurity Centre, the variant surveillance pipeline, the genomic capacity at Sanger. I wonder if it's all standing ready to be scaled and put to work. I don't think so. I think it's all been taken to pieces and we'll have to start all over again. So that is very disappointing and worrying to me. I think that there have been some very short-term decisions on that. Secondly, this is happening at exactly the same time as some pretty punchy testimony in the US Capitol Hill, as John Erdman, the CIA operations officer, is testifying about the CIA's own scientific analysts who he says repeatedly concluded between 2021 and 23 that COVID definitely came from the Wuhan lab, and that those conclusions were buried, rewritten because of pressure from the American CMO equivalent, Dr. Fauci,
yeah,
who personally shaped which experts the intelligence community were allowed to consult and basically suppressed the Wuhan conclusion, partly because of funding that his agencies had put into the market and scientific experiments that he had personally sponsored. Now, this is confirming, it would seem, what some of the skeptics about the origins of COVID have always maintained. It does seem to be very emphatic, clear testimony from someone who was at the heart of CIA intelligence. I can't form a complete conclusion on this, but I have a feeling this ball is going to bounce a bit more. And there was, for me, a pretty devastating moment when the senators said, we'd asked for all the documentation on this to be revealed. It got put into an act of Congress, and they coughed up 4 pages or 8 pages, which were mostly redacted. It did trigger in me some skepticism whether we've actually seen all the papers on this and whether there might be more to come. So this feeling that we're not being told the whole truth. Listen, on this hantavirus thing, my anxiety levels are not pinging. But that feeling that we're not being told the whole truth, either by the authorities or by the WHO or by the UN, it is it does speak to the damage that trust suffered during COVID when people were not straightforward. So I don't know if you feel the same, Steve.
I do, and I think that goes to the quote we read out just at the start of this piece from Tedros, where he says one thing but then the other, and he caveats it, and that always makes me suspicious. So I think there's 20 Brits that are at Arrow Park at the moment in Merseyside, right, and they're going to be there for 72 hours from earlier this week, and then they're going to have to be asked to self-isolate at home for a further 42 days. So presumably they will do so, but they're obviously not under lock and key. The thing about cruise ships is interesting, isn't it? Because if you look back in relatively recent history, it was norovirus, which you can imagine why that might spread around a ship community. Legionnaire's disease, remember that in the 70s and 80s on cruise ships? And then I presume you might have been a minister at the time, but do you remember the Diamond Princess? It was in early 2020. I think it was about 700 passengers got infected with COVID and while they were being quarantined off Japan. And cruise ships don't create viruses. Let's be very clear. And my former constituency in Winchester had a lot of its local economy tied up with the cruise ship industry, which seems more popular than ever. But I think they do expose weaknesses in how we as human beings live closely together. So yeah, it'd be interesting to see whether Steve, this hits people's confidence in them.
It's heartbreaking. I mean, I love cruises. I've been on cruises.
Have you?
Yeah. They're very, very relaxing, and you have to adhere to this regime, and it's therapeutic. Really love it. I'm a big.
Do you know what? I wonder. This could be a cycle helmet moment for us, James. I had used to go down onto the launches of big ships because for the constituency interest that I said, and I took my daughter once. We went and looked around one of the new ships before it was ready to go out, and I just thought, God, I could think of it. Every holiday that I could think of, I'd rather do more than go on a cruise ship.
Yeah, I understand, and I like the big spaces and the mountains as well. But I would try it. It's like going to a spa or something like that. You have to fit in with this regimen, and you have this feeling. It appeals to something in our human inner feelings about journeying the sea and being part of a larger community and a program of activity. No, it's really, I mean, you get off the cruise really relaxed. I mean, it has a very... Anyway, I am strongly in favour of cruising.
You are pro-cruise.
I am pro-cruise, but listen, these are petri dishes of the most extreme kind. They are highly contained. Everyone's very close to each other. Everyone's breathing on each other. the ventilation typically doesn't work very well, and the viruses get round so quickly. And so the moment you have anything contagious, you have to just close the ships down. You can't have ships going around full of viruses. So yes, I think ships are a really big problem, and it speaks, I think, of a bigger issue, Steve, which is I get pressed a lot by people whose judgment I trust, that we have got this idea of ventilation completely and utterly wrong in the 21st century. The Victorians understood it really well. That's why we have sash windows and high ceilings and cross ventilation, classrooms with those big windows on them, because they knew that if you kept the wind blowing through the house, that was a way of stopping viruses from getting around. Meanwhile, building regulation after building regulation makes our houses more and more tightly constrained. Air hardly moves at all, double glazing all over the place. Of course, some of this is environmental and climate change, but some of it's also a sort of modern resistance to fresh air and any feeling of a draft or discomfort. That's incredibly bad news for our children. We have the same problem with allergies, which one day we'll get around to talking about. But I wonder whether one of the reasons why these pandemics have hit us so hard in modern times is that our buildings themselves are just absolutely optimized for the spread. And maybe we need to rethink our building codes. It'll take a long time to rebuild our current infrastructure. But what do you think? I think we've got this one wrong.
Winchester Hospital, which I spent a lot of time in when I was a constituency MP here, is up on the hill. And it's up on the hill for exactly that. Florence Nightingale, it was one of her first hospitals. That's why she put it up there. So that exactly the air blows through. Just finally on cruise ships, one thing in its favour, to contradict myself, is that when I was last down there visiting a cruise ship, they told me that you can take your dog. And they had pee posts where the dog can go do its business. So that did. I said to my wife, does that make us more likely to go on a cruise ship? And she said, less likely. So, yeah. Anyway, we're going to take a very quick break, and then we're going to come back with our 2 listener contributions.
Thank you very much for our listeners who have sent us in all manner of messages and feedback. And we're going to start with a voice note from Dr. Tony Rayo.
Hello, Steve and James. I was an old age psychiatrist working in Bermondsey, an area in southeast London, for 23 years before retiring a couple of years ago. The north area of Southwark had probably one of the highest rates of alcohol-related morbidity and mortality in the whole of England. During that time, I was able to provide data that eventually helped to set low-risk drinking limits and also guided the introduction of screening for alcohol consumption in general practice among middle-aged and older people. I also held a spotlight on this health topic through the media for probably around 10 years or more, through documentaries, but predominantly through print media, in particular The Guardian and the Daily Mail. The problem is that since I retired, I've just felt that the topic of alcohol and the effects on public health have all but disappeared. Now, I know that our century-old drinking culture of what I would call Scandinavian drinking has never been shaken off and probably never will be completely. My concern is that with government interventions for obesity and smoking, alcohol consumption and this whole myth of a pint of beer a day is good for you, or that red wine somehow contains compounds that are going to protect you from stroke or heart disease, are, from an evidence-based point of view, not really holding their own. The 2012 pledge for a government alcohol strategy has just disappeared into the ether. We know that campaigns of any sort addressing public health problems, including alcohol consumption, have proved to be worse than useless. So my question is, where do we go from here at a policy level?
Yes, interesting, Tony. Thank you very much for that. Retired clinical practice after 20 years, talking about alcohol-related health problems, Tony said. My goodness. So we treated smoking, James, as an addictive commercial product, is how I look at this. I think we still treat alcohol as a lifestyle choice. We talked a bit briefly, didn't we, at the end of last week's show about this when I was ranting about alcohol at airports. And I think Britain's relationship with alcohol now is where smoking was 30 years ago. It's sort of culturally embedded. It's politically protected in many ways. You know, you always give a cheer at a budget, don't you, for cutting the pint, the price of a pint, as you said last week. And then it's medically devastating. So I think we are treating alcohol harm as an inevitability instead of a prevention policy failure, which is exactly what it is. And the only final thing I would say on this is that corollary, I suppose, to Tony's note is that there was a story this week that said that UK alcohol deaths fall for the first time since COVID. I think actually if you read the story, it belies the headline. I think you're talking absolutely minimal gain, to be honest. The UK recorded still just short of 10,000 alcohol deaths in 2024, and that was down very slightly on the peak of 2023, but it's still dramatically above pre-pandemic levels. And it tells me men are still twice as likely to die from alcohol diseases as women. It tells me that Britain has a problem with the grog.
I would put it differently, Steve. We treated alcohol like we did with gambling as being an acute problem that really and I did a lot of work on this 10, 15 years ago. We used to talk about domestic abuse, violence in provincial towns, the breakup of families, as though the only problem with alcohol was people who had an acute alcohol addiction. And the answer to it was to spend more money on addiction clinics. That has been a really big problem, but in some ways has dialed down a bit. But it isn't just an acute problem like with gambling. It's the chronic problem that is the issue. And this idea of alcohol deaths is a tricky one because it doesn't speak to the millions of people, a lot of whom are men, who are carrying too much weight. And if you look at their calorie intake, particularly the avoidable calorie intake, a ton of it is alcohol. So it is the drinking every day or several times a week and maintaining a sort of a habit of drinking all the way through your life that leaves people in their 50s and 60s, you know, quite badly damaged and open to cancers, heart disease, musculoskeletal. Just, you know, it means it contributes to the unfit nation that we have. And that's where the big damage is. So it's really turning it into a public health problem rather than a policing and Home Office problem. And that penny has not dropped at all. It really hasn't, I don't think.
Yeah, I think the lesson from tobacco, it wasn't that we Brits suddenly become virtuous. It was that the policy changed the environment around the behaviour. And I think alcohol it's the great unfinished business of prevention policy for me. And we had, you and I both know Sir Ian Gilmore, who runs the Alcohol Health Alliance. He came on the podcast, episode 52, if anyone's interested in looking back on the archive. And they're always consistently pushing for, among other things, minimum unit pricing of alcohol. And I know a bit about this. During my time as Public Health Minister, Scotland was doing its trial on the subject, or it was just introducing, actually. And they are seeing the rate has begun to fall in Scotland, which some public health experts put down to minimum unit pricing. You know, we talked earlier in the show about Number 10 not getting behind ministers and not agreeing things with ministers. I think the truth is I don't think that the Secretary of State, Jeremy Hunt, then at the time wanted to go there either, but Number 10 certainly didn't. And the line that I constantly had in my ministerial folder for my topical question notes was, you know, let's wait and see what happens in Scotland. And we never went there, and I really can't see us going there. And I suppose then everything looks back to the politics of health, doesn't it? So the bit that we were talking about at the start of the show, is our government really strong enough to go there on alcohol control? Is it really going to do that? I can't see so. And from what we said earlier, I think that's very unlikely.
Labour have been terrible on these public health issues. I think typically they are very, very wary of challenging their own voters on gambling, on drinking, on smoking. You know, it's the John Reid thing. You know, what about the poor old cleaner who comes home and all they want to do is have a relaxing cigarette? Why should we stand in their way? I mean, give me a break.
Their one last pleasure line.
Their one last pleasure. I mean, really? So you're advocating people poisoning themselves and the state supporting that? I mean, that's just crazy talk. I don't know. I could go on about why I think Labour politicians are not reliable on these subjects. What we haven't seen, a very heartbreaking moment for me was Rishi Sunak, who's never touched a drop in his life. He runs 10K in 47 minutes, which is pretty flipping good. Fastest Prime Minister by far.
How nauseating.
I know. He is in great shape, and he lives a Spartan, life and conforms with his religious commitments. I mean, it's really impressive. But he never spoke of that. And there is a cringe-making photo of him standing next to Boris, with them both holding brimming pints of beer, being a bit of a lad, when that is an absolute anathema to his own personal standards. And it speaks, I'm not trying to make a personal criticism of him, but it speaks of a political culture where no one is brave enough to say, do you know what, I used to drink a lot, but I don't anymore because it's obviously very bad for you and I function much better if I don't drink. By the way, Brits drink a bit too much. And of course, we all like a drink at the weekend every now and again, but it's absolutely fine not to drink during the week. Most people probably should do that. I mean, they can't speak openly about that. And it does contribute to it. And one of the reasons why I am supportive of the minimum price policy, not because it is devastating evidence that it's moved the needle hugely. In fact, it's a clunky, tricky, not hugely straightforward policy. But it is a bit of a signal that says, do you know what? Drinking loads of cheap beer is not a great idea. So we're, as a state, going to mandate it. Now, you shouldn't use tax and the law to try to change culture. I know that's a good rule, but every now and again you need a little bit of leadership. And if you don't have basic measures like that, I don't see how we're going to turn this one around.
I like Tony's. I think what prompted Tony's question. He said, "We've got to the codswallop of a pint a day is good for you." Because do you remember a couple of weeks ago we were talking about that ridiculous study that turned out to be, who knew, sponsored by a German beer manufacturer, about a pint a day being good for you. And I think that's what maybe prompted.
Well, we still
Tony.
have a minimum daily drinking guidance level.
Yes,
daily drinking. Hey guys. Daily drinking is not a good idea. You have one glass of wine every day. That is a problem, because every day your body reacts to that alcohol and is in a state of, mild toxic shock and inflammation. And that's what will increase your chances of heart disease, dementia, and the whole rest. That's why you will drift into your pensionable life in poor shape and be unable to contribute to your family, community, and the taxpayer.
Well, fine. Thank you to Tony.
Sorry to
really appreciate you doing it, Tony. Another one that we've got here, and you can join in the conversation too on WhatsApp. Send us a voice note, 0333 404 6507. And we've also had this one from Tej, who is a resident doctor.
Hi, Stephen James. My name's Tej. I'm a resident doctor, Foundation Year 2. I work up in Derbyshire. Really big fan of the podcast. Great way to keep up with health policy news. Just wanted to ask a question about the shift from acute to prevention in terms of resources and funding. The way I see it, there are really three ways to do it. You either have to find new money to put into prevention, which there is none. You have to pull money from acute to prevention without creating headroom for it, which means you'll essentially be not treating people in the hospital, which you can't do. Or you have to figure out how to create the headroom in acute care to move that money across into preventative care, which seems to be the kind of golden question going around all the health economists and policy makers I've been speaking to so far. Just wanted to hear your take on that and what the key steps are in getting that done. Thanks very much.
Wow, interesting message, James. Thank you, Tej. It's a really thoughtful message and really kind things that you say about the podcast. James, this is where I, very nerdy, get out my 10-year plan document, the epitaph to Wes Streeting. And I've quoted this before, but I think it's worth saying it again here. Page 28, so this is in the whole hospital to community section of the 10-year plan. As we do more in the community, funded by a reduction in hospital share of total NHS expenditure, we will reduce demand on hospitals. And that goes to the heart of Tej's point, which is double running and funding prevention services alongside funding the acute services. And that hasn't really happened. And I think that there will be all sorts of problems for a new Labour leader and a new health secretary in actually making that happen. But Tage's point is that unless you create the headroom in acute, which is what he's saying in his questions, then we're never really going to do the double running that we need to do without a greater increase in budget, which of course isn't going to happen either. So I thought it was a really thoughtful question, and especially coming from somebody who is right there in the acute sector at the moment, dealing with the day job as well as thinking about prevention. I was quite heartened by his question, actually.
Listen, it's an incredibly thoughtful question. And this question of double running comes up all the time. I've got quite extreme views on this.
Oh, so, good.
Tage's question is perfectly reasonable, but can I just say, I think this whole argument about double running is total cobblers. I mean, it's just nonsense. Every single business in the land has this challenge every single day of the week. All of our business models are always in a state of flux, and we're seeing a state of flux being huge at the moment. And so everyone who runs any organization has this same problem. How do I keep going with the stuff I've got on today and plan and spend some money to prepare for the future? And the answer is you save some money, because some of the money you're spending today is a waste of money. And the health service is wasting huge amounts of money. What, you think out of the 220 billion quid we're spending every day, all of it is thoughtfully spent? I mean, it's just rubbish. A very egregious example is in the medicines bill. We over-medicalise massively, and there are a ton of people who have prescriptions which go straight into the dustbin. There are billions of pounds in that. It won't pay for everything, but that would be one example. And so what you do is you work through the system and you find 3, 4, 5, 6 examples of that, and you put together some money to be spent on the stuff you need to do for the future. On that list should be some of the late stage interventions, which are incredibly expensive and may not give either quality of life or value for money for the taxpayer. And we shouldn't have that as a sacred cow. We should definitely tackle the question of how much money we spend, both in terms of research for late stage cancer drugs and for purchasing them. And that is a tough thing to put on the table, because there will be families out there who want to spend the last few weeks with their loved ones. But there are also a lot of people who think, why are we doing this? This is incredibly painful and uncomfortable. So that culture of late stage that we're in at the moment, I think, does need to be scrutinised. And that came up a lot in the assisted dying bill. So you find some money. And by the way, prevention doesn't need to take 30 years to work its way through. I mean, to take an example of smoking, if we stopped smoking tomorrow and said there will be no more smoking, heart attacks would reduce by Christmas. That would have an immediate effect, because when you smoke, it thickens the blood, and the thickening of the blood encourages heart attacks. And a ton of people, 6 million people, would have thinner blood by Christmas and have fewer heart attacks. And there are many, many examples of where prevention interventions would make very swift impact on the bill. Now, I am ambitious that one day we won't have so many hospitals. I think it'd be hard to argue that that's around the corner, but it's not difficult to explain where we might get resources for prevention tomorrow. It really isn't, Steve.
One of the concerns I have about this is the capacity, the people, the sheer people capacity to do any of this. Not in terms of numbers, because it's not all about, let's increase the size of the workforce, but just the mindset of those that are left in ICB land, because so many people have either been shown the door or have found the agency to find the door and have therefore left the system. That worries me. And then looping right back to the start of our conversation today on the podcast was about single patient record and about data-driven productivity. That's where I think is the heart of Tage's question, is that him in the acute sector, his colleagues in primary, his colleagues in community, and his colleagues in social care, the join up is just not there. Therefore, the productivity is so poor. And I think that could be the answer to double running, which I agree is poppycock in many ways and sort of completely missing the point. But I really like the fact that he has posed the question, and please keep listening to the podcast, because we enjoy what we hear from you and we enjoy debating your points. There you go. We still have a health secretary. as we're recording.
Yeah, that's
well, we
right.
think anyway. You never know. but either way, I think, Wes's tenure as Health Secretary is coming to an end, and I suspect sooner or later Keir Starmer's tenure as Prime Minister is coming to an end, and we will, on future podcasts, reflect on their time and what it's meant for health. It might not take a huge amount of time, but you never know. Might be something exciting to come in the next few hours. Listen, James, nice to see you. Have a great day. Nice to chat as always. Thanks so much for listening to our podcast. We really hope you enjoy it. You can find us on all the usual social media channels. You can WhatsApp us, we said. Also email us. Many do. hello@preventionisthenewcure.com. This episode, presented by myself, Steve Brine, and James Bethell. It's produced by Callum MacDonald, and we are part, are we not, of the Shortbread Media family. I'll see you next week, James.
Thanks, Steve.